Hello, everyone, and welcome to Substance Use Across the Lifespan, Supporting Every Stage, an immersive podcast series created in partnership with the Opioid Response Network. I'm Marlene Martin, an addiction medicine physician and longtime member of the MRSA community. For those new to the podcast, MRSA is a national organization dedicated to bringing together disciplines and perspectives to strengthen substance use care through collaboration, evidence based practice, education, and advocacy. This podcast series explores how substance use care evolves across the lifespan, from childhood through older adulthood, highlighting the developmental, social, and clinical factors that shape care at every stage. Let's explore today's episode. Despite strong clinical evidence supporting compassionate, evidence based care for pregnant and postpartum individuals with substance use disorders, many clinicians struggle to translate that evidence into daily practice. Gaps in screening, fragmented referral systems, stigma, and inconsistent access to medications like buprenorphine can leave patients navigating barriers at every stage of care. In today's episode, we explore where care breaks down, how systems and stigma shape clinical realities, and what practical, trauma informed strategies can be implemented immediately. This conversation focuses on implementation over theory, offering concrete tools clinicians can use right away, from language shifts and screening approaches to documentation practices and pathways to medication access. If today's discussion prompts reflection on how your team supports pregnant and postpartum patients, we invite you to continue learning with this episode's companion toolkit at immersa.org. Joining us today is our host, Dr. John Larrabee, a physician with the American College of Obstetricians and Gynecologists, whose work centers on providing individualized, patient centered care across every stage of a woman's life. He is joined today by Mel Ramage, director of the North Carolina Perinatal Substance Use Disorder Network, whose work advances evidence based treatment, access during pregnancy and postpartum, and Dr. Andre Jones, an internationally recognized leader in women's substance use disorder treatment, neonatal abstinence syndrome research, and global policy development. Presenters report nothing to disclose. We're grateful you're here. Let's begin.
Thank you, Marlene, and welcome everybody. Thanks for joining us today. I'm your host, John Larrabee, and today's episode focuses on tools to alter the stigma and bias in our clinical communication, as well as in the systems we work within. Despite our best intentions, we might just be perpetuating unhelpful patterns that undermine our care. We also hope to discuss screening questions and, equally important, what to do with that information. And discuss patient access to life-saving medication for opioid use disorders. What can clinicians who may not feel like experts do to simplify access to buprenorphine and methadone? It's a lot to cover. And fortunately, we have just the right guest to help us understand these issues. We're joined today by Mel Ramage and Andre Jones. These are two really remarkable clinicians. They have a wealth of experience working in this space, as well as creating programs tailored to people with substance use disorders. We're so glad that you're here. Mel, welcome.
Hey, John. I'm glad to be here. Thanks.
And Andre, welcome to you.
Oh, thanks so much, John, for having me. It's great to be here today.
It's great to have you both. I really appreciate it. And then right before we kind of jump in, I just want to kind of help frame this conversation that we're going to have today. And I want to start by sharing what I hope will be the themes that we get through. The first is that the concept of small language and workflow changes can really significantly improve patient trust. That's what we hope improves outcomes for our patients. The second thing is that we have good evidence-based substance use disorder tools. The challenge, of course, is using them. And like I said earlier, we don't have to be specialists to help patients access these life-saving medications. So let's go ahead and jump in. And again, thank you both for being here. Okay, Mel, the topic of delivering evidence-based perinatal substance use disorder care, it's inherently loaded, I believe. What's one of the biggest clinical challenges that you see in caring for patients in this context?
Yeah, John, let's start off with some agreement. I also think it is inherently loaded. And when we think about perinatal substance use disorder, that care doesn't usually break down because we lack evidence. We actually have a strong and growing base of evidence to tell us how to navigate this. Where things most often fall apart is at the point of implementation, and that lack of follow through in the healthcare system that directly impacts patient access to care. So our system and we right support a barrier to access. Access to care impacts 100% mother baby diet outcomes.
Okay, so when you're saying implementation, where does that break down in real life for us?
Yeah, stigma. The primary barrier is stigma, and when I'm talking about stigma here, I'm not just talking about individual attitudes. I'm talking about institutional stigma, systemic stigma. It shapes who and how we screen. It shapes how we document, how we design workflows, how safe patients feel about being honest with us, and certainly who gets access to medications for addiction treatment.
Okay, good. And we're going to dive into, I think, all of those things in time. But before we do, Andrea, you have quite literally kind of written the book on this topic. You co-authored one of the sort of foundational texts in this field. So, you have seen this field develop, and in what ways are we successful at
Yeah.
improving this access? What have we done well?
Yeah, I love that. What have we done well? I like to start with what is working. So I want to talk about three main points about how we have made substantial progress in the adult addiction space. So three things come to my mind immediately. One is that thanks to our legislators, we have removed that data waiver for buprenorphine, which means that any prescriber in the United States can prescribe buprenorphine. That means over a million MDs, plus about an estimated 400,000 advanced practice providers can prescribe buprenorphine. And depending on even the state regulations, there's some pharmacists that can also prescribe this life saving medication. The second advance that I'm really excited about is that we have loosened those restrictive regulations around methadone. That was one of the silver linings of COVID. So now it's easier and faster for patients to get multiple days of their medication. So that saves them time away from their job and their other life things. It saves them the expense of transportation. And then SAMHSA has also sent out a Dear Doctor letter to opioid treatment providers saying that best practice for pregnant patients is split dose methadone. So dividing that total daily dose in half or thirds or fourths. So we know from science that that improves both maternal and child outcomes. And the third thing that really excites me about this space is what we're doing training future physicians and residents so that there's the white coat day and people are getting naloxone in their white coat. So there's a lot of things that we've done to expand access to care.
Yeah, that's fantastic. I didn't realize that it was happening in the those new white coats that medical students get. That's fantastic. And we're gonna spend some more time on the medications in a little bit too. But let's go back to what Mel started and where we started, because that's great progress. But why is this not enough? Why are we here talking about this today?
Yep, because perinatal care can scare people. There are additional layers that are added that aren't present in kind of routine addiction adult medicine care. So, when we're talking about pregnancy, we're talking about two entities, we're talking about child welfare involvement, depending on what state you're in. There are legal risks in addition to social risks with being identified and treated for having a substance use disorder during pregnancy. And all of that can intertwine with stigma. And that stigma, I've heard my patients say, when you're a pregnant patient, you are at the bottom of the barrel in terms of stigma, the most stigmatized. And then that radiates out to the people that are caring for them. So even the best intentioned clinicians may hesitate to treat our patients, not because they don't care, but because they're scared of what to do because the system hasn't equipped them with what to do and how to translate the evidence that we've generated into practice, what to do at the bedside. The biggest question I get from providers is, how do I even begin to ask if my patients have substance use disorders during pregnancy? Because I don't know what I'm going to do when they say yes.
I think that's the crux of the issue. I mean, what do we do to support patients? What I hear you saying is that implementation is the next step. And you both mentioned there's plenty of evidence, tools, and available. We're all a little bit anxious about using these tools. Let's start with the 5Ps, Mel. That's a common screening tool. And what is it? Tell us about it.
Yeah, John. So the 5Ps is one of several validated verbal screening tools we can use in perinatal care. And I think for anyone listening to this, if you're wondering where to start with implementation, this is where you start. You start with your screening practices, right? And I like to break it down into the what and the how. So, I think all clinicians are well versed and trained in what is screening, right? And what is substance use screening in the perinatal space. And what we haven't done is really that this screening must be normalized, right? It must be part of routine perinatal care, just like screening for depression, hypertension, or diabetes, right? When it's framed as standard care applied universally and paired with clear next steps, John, implementation gets significantly better.
Got it. So, folks like me that are working in this clinical and at the systems level, even, how can we improve this implementation? We have this good tool. How do we make it really shine?
That's right. And what you're asking is really driving home, like screening alone isn't enough. There has to be that clarity around what counts as a positive screen, like Andre mentioned. If it's positive, what happens next? What if my patient says yes? What do I do? Do you have that assessment tool ready? Are you already using DSM-5 criteria to help support making a diagnosis? Is that process already embedded into your workflow? It's the clinician's responsibility to assess further and make recommendations for evaluation and treatment. Screening is the doorway, not the endpoint, right? And I think that's where we're stuck. I think across the United States, we're like, "Whoa, we screened, done, peace out," right? So that challenge in that prenatal care and addiction medicine have historically been siloed. Like I get it, right? They have been two ships in the night that have not met, right? So the next steps aren't built into everyday practice yet for most clinicians. That's the change point. So, right, like one of the challenges after listening to this podcast would be asking these questions. Who administers our perinatal substance use disorder screen in our clinic? Where is it documented? And whose responsibility is it to review it, not only clinically, but then review it with the patient, right? And then if number one, do I clearly know what a positive is on the screen? And if it is positive, what are my next diagnostic tools to be sure I have what I need to make an assessment? And then just like everything else in the diagnostic model, right? What treatment and referral pathways exist, and do I have that knowledge? And if not, how do I get it? Right? If you cannot answer as a clinician, if you cannot answer those questions from front to end, then that's where your work begins.
I mean, too often this is just another checkbox, right? This is the screening, like you say, you check it off, you move on. And so, how do we keep it from not being just a checkbox? What are those skills that we need to develop?
Yeah. So what does a checkbox look like in real life, right? And that's the other part of this. When I said the what and the how, so right, that pathway's the what, and then the how starts with consent, right? We have to let patients know that we ask everybody these questions. We need to explain why we ask these questions. Why is this important, right? We clarify what would happen with the answer. And we're transparent about next steps. And all those things happen actually before the screen, right? Screening should never feel like a trap. And for clinicians who might say, I don't know how to do that part, I don't know how to do this, I would not so gently challenge that if we were talking about screening for gestational diabetes, right, that would be unacceptable to say, I don't know how to diagnose that. Right? Diagnose that. Substance use disorder is a medical condition. We have diagnostic criteria, we have treatment, we have evidence based pathways. We just have to integrate them into care that we already provide.
I mean, you're saying that we tend to treat substance use disorders differently than we do other things, right? We aren't following through with the next steps in assessment and treatment or referral like we would say with gestational diabetes, which you know well, or a worrisome screening mammogram, right? I know the pathways that I need to take once those things screen positive. And I think that anxiety maybe about the next steps for perinatal substance use disorder is one thing that holds us back.
Yes, absolutely. And so, yeah, again, like we laugh and though it's not very funny, like, right, you would not send someone as an OBGYN, you would not send someone for a mammogram without also being ready for that result to come back and what you may need to do with it. And that might not, right, like everything else, that may not mean you know all the answers of all the possible, reads, right? But that's when you would phone a friend and reach out, right? So that's one part. And then I think the other part I want to add here, and John, you and I have had lots of conversations about patient care and how we can show up for patients. I think the other part that is the how is that we actually have to be practicing this new pathway, right? Not only do we have to have the pathway, but just like the mammogram screening, right? Like we have to be able to practice what that pathway looks like, and that's actually how we can show up for patients better, right? With more humanity and clarity.
And what makes that practice real is having a workflow.
That's right.
I mean, we have to implement these workflows and kind of complete that circle of care. And it just makes me think for the listeners, like you said earlier, while we're talking about this, think about the way your own clinic, maybe, or your office screens for these substance use disorders. What's the process? And where is there room for improvement, which is where we all need to look. Okay, Andre, one area that I think about that where we could all make improvements, like we're talking about, is the language that we use. I think many, rightly so, many pregnant patients probably fear judgment when discussing substance use. What specific language and approaches have you found that are most effective in creating maybe a safe space for honest disclosure? That's what we want.
Right. We want to have change happen at the speed of trust. So, behavior change happens at the speed of trust. So, it is our job to create that safe environment for patients to trust us, to be able to share honestly what is happening so we can help them. And that starts with the words we use. So, what is the role that that substance is playing in their life? There are so many things clinicians have no control over, but every day, the words we use, we have complete control over. So we can meaningfully reduce that stigma by making the small intentional changes in our language. For example, like Mel had mentioned a minute ago, normalizing those substance use questions, right? We ask all of our patients this, and then following up with, well, I ask all of my patients about substance use as a part of their whole person healthcare. Do I have your permission to ask you these questions? And honoring if they say no, then hey, no problem. Thanks so much. I'm going to check back next time. Um, and if they do say yes, then asking them things like in the normalization realm, how many days are you drinking alcohol each week rather than do you drink or you don't drink, do you? Right? How many days are you using cannabis products each week? And if they are reporting days of use, then charting it in a very observant, non judgmental way. Patient reports 5 days of alcohol use and 2 days of cannabis use weekly, rather than, you know, patients misusing alcohol and smoking cannabis like a smokestack or something. So we've discussed the role that the substances play in their life. That helps them feel safe and normalizing what's happening. And she might say, I'm using alcohol because I can't sleep at night, or I'm using cannabis because I'm nauseous every morning. The beautiful thing is we have a menu of options to help with those behaviors that don't have to be the alcohol or the cannabis. So that allows a conversation for different things to help manage those reasons why she might be using. So,
What I'm hearing too is that the small changes away from clinician judgment to objective support, which I think is the right way to frame that, that's what can reduce barriers and start those conversations. Okay, Mel, Andre touched on documentation. There's rapport building, non judgmental languaging during interviews. We all can strive for improvements there, no question. But what are some things to consider when we're documenting these conversations? When for perpetuity, we're setting something down in black and white? And how does the stigma show up in our documentation and our charting?
Yeah, absolutely, John. It's not just what we say, but what we write or what we type. I guess is the better way to say it. Stigma shows up in charting through language, and then in two categories: terminology that we use, and then patient-centered versus non-patient-centered language. And that non-patient-centered language that shows up when we write things that imply intent or blame, and using certainty in our description of something when really there was uncertainty for that patient, right? Words like or terms non-compliant, dirty urine when talking about a urine toxicology, right? Or documenting substance use as a moral failing rather than using our well educated, objective clinical finding skills, right? To write those down. All those things, those quietly shape not only how we see that patient, but all future clinicians perceive and treat that patient when they read our note, right? Chart notes don't just reflect care, they actively influence it. So that documentation needs to reflect that clinical clarity and support, not judgment. And that's how screening can become a bridge to care as opposed to a barrier, right? All those language and terms that we use really can open a pathway as opposed to block and put that barrier up that we talked about earlier.
It'd be easy for us to reinforce that negative, the boundary, and the mistrust in our languaging if somebody were to see those chart notes in the future.
Yeah, it's like putting mortar against the wall, right, that we built.
Exactly. I love it. Andre, what are one or two changes that we can make, realistically make in the short time and that we have with patients oftentimes? What are some changes that we can realistically make to start making this documentation better?
Yeah, and I'd love to answer that question, and I wanna also emphasize that when we were talking about pregnancy, we are, potentially opening these charts up to Child Protective Services, and how you write what you see and what your clinical care pathway is can have ramifications, lifelong ramifications for the pregnant patient and for their child potentially later on. So, two powerful changes that you can start right now is shifting to that person first language. So, our patients are people that have a substance use disorder. They are not an addict, they are not addicted, but it is the person and they are not defined by their illness. The second thing that we can do is going back to what Mel said, documenting those observable facts and being comfortable with observation without certainty. So, for example, if you have a urine drug test that has come back confirmed for metabolites of cocaine, you're going to write just that. You're going to put in there what type of test it was. What were the cutoff levels that were being used? And it is not that they have a diagnosed substance use disorder because we don't diagnose substance use disorders with any type of biological testing. It's one tiny piece of information in the overall pattern that goes into defining what a substance use disorder is and how severe it is.
Yeah, we don't want to encourage the whole person definition by an errant, poorly documented response. So how, and I guess that touches on it, Mel, but I'm curious about how changing the chart language, how does that really improve care? You mentioned, Andre, about childhood issues, but in terms of these patients, like what does it really do to help them?
Yeah, absolutely. So we have a lot of actually research in this space across substance use and perinatal substance use. Our language shapes access. When charts reflect respect, clinical reasoning, and openness to engagement, patients are more likely to stay in care. Clinicians are more likely to offer evidence-based treatment, right? And both of those things improves outcomes all around. Reducing stigma and documentation is it's not a courtesy, it's an implementation strategy that directly supports patient safety, patient trust, and improved mother-baby dyad outcomes.
Okay. So if we use this conversation sort of as a template for a clinical encounter, right? Hopefully we've now created a safe, hopefully an open space for our patients. We have eliminated stigma in our documentation. That'd be wonderful. Now, I just want to see if we can. Let's switch gears to consider the next steps. So, what about treatment options? Mel, can you describe what medications for opioid use disorder are?
Absolutely. And John, if I may, I loved how optimistic you just were, right? Like, I too want to eliminate stigma. That is my long-term goal. And anyone listening to this podcast, I would love for you to commit to that, knowing that it is a long-term commitment. But John has told you you have the potential to eliminate it, so I need you to do that, right? And make those drives. But when we talk about medications, and man, what a partner with stigma, right? I think no one listening to this podcast is unaware of the impact of opioid use disorder in this country and overdose deaths, right? And we know that in the adult population, there's been a lot of conversations around access for medications for opioid use disorder. And those medications, there's three of them medications are buprenorphine, methadone, and naltrexone. And buprenorphine and methadone are two of the medications that we use in pregnancy. They're evidence-based treatments that reduce overdose risk, just like in the general adult population. But also in this population, it improves pregnancy outcomes, the use of these medications. It supports long-term recovery, especially into the postpartum phase, which across the nation, the number one cause of preventable maternal deaths is overdose. And that is classically in the 7 to 12 months postpartum, right? So that access, not only in pregnancy, but through postpartum, right? Capital P postpartum, 12 months or more, right? That changes that long-term support. In pregnancy, these medications are not only safe, they can be life-saving. So this is another place where clinical knowledge and clinical practice falls apart for this population.
Yeah, and I can also imagine that many practitioners feel intimidated by these medications and how to use them. I think we know and have been taught that they can be safe and effective strategies to support these patients, but I think it often seems like it might be too much to incorporate in the busy day that I have. I mean, Andre, what do you say to clinicians who feel like, we just don't have the skills to deal with this?
Yeah, I would say you are not alone, that you can phone a friend. There are thousands of friends out there that are doing this work. So all you need to do is start with that screening, that identification, and help patients get the assessment to take the next step for stabilization. So opening up and having those initial steps to create that trust and rapport. And clinicians, there are lots of resources out there to support medication for opioid use disorder access. Making sure that within your system that you have very clear referral pathways. Who are the friends you're going to phone? Are you using that patient-centered language that we just talked about that hopefully you're already implementing? And thinking about that next step planning to prevent care gaps. It's one thing to get somebody started on a medication. Are you the best person to be able to continue that medication? Maybe not, but knowing who to refer with a hot handoff for your patient to go to that she will feel safe going to is, not rocket science. It just takes good communication.
And Andre, I love that the hot handoff is not even the warm handoff or the cold handoff, right? Like the responsibility we have as clinicians that once we diagnose, right, we do the screen, the assess, the diagnose, and that beginning support. Our job is to make sure it goes all the way through to the finish line, right? And John, I just want to echo what Andre said and really call back a little bit to what she said in the beginning of this podcast. So where access to medications again falls apart is implementation, because we're overlooking the simple paths that we use all throughout medicine, right? We can all make a joke, right? Like if I had to go back and go through nursing school all over again, like back in the day, I memorized all those medications, but that was a minute ago, and there's a lot more medications, right? I have to have a different clinical pathway for decision making. So let's say, John, you have someone who comes into your practice, they're on buprenorphine. Let's say they just moved here to the state and they no longer have a prescriber, and they've been prescribed buprenorphine 16 milligrams sublingual daily. You have a DEA license. You do not have to do any additional training because we got rid of the Data 2000 waiver, like Andre mentioned. You can prescribe buprenorphine for that patient so that they do not lose access to that medication like today. right? We don't have to make it harder than it is. They've been stable on that medication. You have a DEA license. You can prescribe that medication, right? Stop. If they're not on medications for opioid use disorder and they want to be, and let's say you've never done that, right? That's where we go back to that phone a friend. Maybe buprenorphine is not the right medication for them based off that patient decision making. And it's a phone a friend to an opioid treatment program that would also offer methadone because that is the medication that we cannot prescribe in the outpatient clinical setting, right? What are the existing pathways we have for other medications that we may write or other case scenarios that patients already fall in? Like, this is not a unique scenario, really, right? When we take it out of the stigma and judgment around addiction, we do this as clinicians all the time. Where are my clinical resources and can I have them ready to go? Like Andre said, who is my phone a friend, right?
We have the skills. Every
That's right.
every doctor, nurse practitioner, prescriber has those skills. It's just getting comfortable, and what makes us comfortable is the people around us and the phone a friend. I appreciate that. Hey, the we've talked about opioid use disorders, but what about other disorders? Tobacco, alcohol, these kinds of things. Are there other evidence-based treatments for those?
Absolutely. Yeah, let's normalize prenatal care providers actually are already, I think this is so great to highlight, already doing substance use treatment prescribing because we have been prescribing medications for tobacco use disorder for a real long time, right? So I love to use that as an example to again level set that we may actually have more comfort than maybe we give ourselves credit for, right? So when we think about substance use disorders and pregnancy, obviously the majority of attention has gone to opioid use disorder, and for good cause, right? The whole opioid epidemic, overdose deaths, that is a critical intervention point that we could not wait on, right? And we didn't, and I'm so glad that we have not. We still have work to do. And perinatal substance use disorder is larger. It's more than just opioid use disorder. There are other use disorders, and we have not only medication treatment for alcohol use disorder, opioid use disorder and tobacco use disorder. But then, certainly, like when you brought up the case example, actually, Andre brought that case example of why other reasons we may use substances. We have other tools in our toolbox to assess what patients may need that is also complementary, right? Like the cannabis use in nausea, right? We can think out of the box, even if we're not using specific medications for this use disorder. Like we have a whole array and menu of ways that we can show up for patients. So addressing medication access includes building these information links of how to prescribe, right? How to think about supporting in addition to those phone a friends. And certainly I'd be remiss if I did not say, right, like medications for substance use disorder, just like medications for other medical conditions, are not the end all be all. They are important tools that are evidence based to be offered in pregnancy and postpartum. And there's additional tools that we can be talking about, like we do in other scenarios, right? So if someone has gestational diabetes, yes, we are discussing medication management for a blood sugar management, but we're also talking about diet and exercise, right? So when we apply those same pathway principles that we already know as clinicians, then we're thinking about what other additional substance use specific behavioral health supports can support patients, and how, again, do we get access in our clinics to have those referral pathways.
Yeah, it makes sense. And the pathways for those times when you get stuck, Andre, how do you connect with those people that have the expertise? And somebody's in my clinic and I'm feeling stuck about what those next steps are. How do I connect with these people? How do I phone the friend?
Yeah, absolutely. There are so many different communities that are out there. And so I'm going to highlight a number of them, and they are also in our toolkit. So I encourage you to take a look. So the first one I want to highlight is the American Society of Addiction Medicine. We have a special interest group on women and addiction. There is a listserv that you can join. You can ask any clinical question. Please let it be de-identified, but general clinical help questions. There is a wealth of knowledge in this brain trust of this group that has been around for over a decade. There's also Choices International, which is a free listserv also that you can ask questions and get answers and connect with other people that are doing this work, that have been doing this work. There is a Yes We Can line that's provided by the Washington Society of Addiction Medicine, and they answer all sorts of questions about perinatal withdrawal management, initiating and titrating medications for substance use disorder. What about pain management in before birth, after birth, and how do we care for the newborns and the entire family, whole person care? There isn't a question that you can ask that somebody won't have an answer for. And there are also websites like Doing Right by Birth and ifwhenhow.org that can give you some of the nuances around your particular state for what are the special confidentiality or legal rules that you need to do this work. So I encourage you to take a look at our toolkit and know that you are not alone.
Yeah, definitely. And there are plenty of resources to help us, just like in any other facet of medicine. I'm going to look for help when I get stuck, like we all should, and there's plenty of resources out there. Okay, we're nearing kind of a wrap up phase, and I feel like we've sort of worked through a template for doing better with our languaging, our documentation, and thinking about how to actually implement the yes answer from a patient. Andre, what final advice might you have for clinicians that are struggling to find compassion? That's a big important part of this, and for those folks that are struggling to find that compassion when they're caring for them, what do you recommend?
Yeah, the first thing is that you have to hold the hope for the patient when they can't hold the hope for themselves. And if you don't believe in the patient, the chances that that's going to show up in your documentation and the chances that the patient is going to have an optimal outcome become less. So when you are struggling with compassion, I invite you to pause and look at the patient and remember that the frustration you are feeling is not the patient. Stigma is not the patient's problem to solve. It is a clinician, clinic, and systems issue to solve. So when that compassion feels really hard, it's a signal not to blame the patient, but to look upstream and figure what is it that needs to change? What are the tools that I need to have to feel most competent to be able to care for this patient? And my final piece is that every time you walk into a patient's room, I want you to flip that script from what's the matter with you, patient, to what matters to you, patient.
From what's the matter with you to what matters to you? I like that. That's awesome. That sounds like kind of the perfect sentiment to wrap up this discussion, you guys. So before we go, though, again, I want to just highlight a couple of things before I thank all of you for being here today. The first, I think, is about considering our own biases. We talked about that. We want to be aware of those challenges and that those small changes in the way we language and chart are going to improve that trust and improve outcomes. And we have great evidence. We know that. We just need to use it. And like I said earlier, we do not all need to be specialists. We need to be able to access those specialists if we get stuck, but we all can do this and treat these patients. Mel, Andre, I thank you both so much for joining us today. We really appreciate your time and your expertise.
Thank you, John.
Thanks, John. Thanks, Mel. It's great to be here.
And to our listeners, we appreciate your time, your patience, and your willingness to learn with us as we strive to make all pregnancies safer. That's the goal. If you found this episode helpful, we encourage you to share it with a colleague or someone in your network. And of course, thank you to Immersive for hosting this event. Take care, everyone.
Thank you to Dr. Larrabee, Mel, and Dr. Jones for sharing your experience and practical guidance. And thank you for listening. We invite you to continue learning with this episode's companion toolkit. You can download the toolkit by completing the episode's evaluation survey at immersa.org. Join us in 2 weeks for the next installment of Immersa's other podcast series, Frontiers in Substance Use Care, Emerging Topics in Evidence, where we explore the evolving landscape of substance use and addiction care. This Immersive podcast series is created in partnership with the Opioid Response Network. To learn more about Opioid Response Network and Immersa, please visit opioidresponsenetwork.org and immersa.org. Technical production is provided by Podpaste. Funding for this initiative was made possible, in part, by grant number 1H79TI088037 from SAMHSA. The views expressed in this podcast do not necessarily reflect the official policies of the Department of Health and Human Services, nor does mention of trade names or organizations imply endorsement by the U.S. government. Disclaimer. The information, opinions, and recommendations presented in this podcast are for general informational purposes only and should not be considered medical advice. This podcast is not intended to replace professional medical consultation, diagnosis, or treatment. Any reliance on the information provided in this podcast is at your own discretion. While every effort is made to present accurate and up-to-date information, Emersa makes no warranty, guarantee, or representation regarding the accuracy or sufficiency of the content featured. The views expressed by guests are their own and do not necessarily reflect the views of Emersa. Their appearance on this podcast does not imply an endorsement by Emersa of them, their viewpoints, or any entity they represent. Unless explicitly stated otherwise, Emersa does not endorse, approve, recommend, or certify any information, product, process, service, or organization mentioned in this podcast. Information from this podcast should not be referenced in any way that implies such approval or endorsement. Emersa expressly disclaims all liability for any direct, indirect, incidental, or other damages resulting from an individual's use of, reference to, reliance on, or inability to use this podcast or the information presented in it.